Okay. Good afternoon, everyone, and thank you for joining us today. My name is Ashley Leahy, and I proudly serve HonorHealth Foundation as Senior Vice President, Major Gifts. Today is far more than a webinar. You will hear from the esteemed leaders of HonorHealth Heart Care, both exceptional physician leaders who are transforming heart care right here in the Valley for our loved ones and our entire community. It has been an absolute privilege to work with so many of you on the line today, donors, partners, physicians, and team members who recognize and understand the critical need for expansion. I want to recognize that we have several HonorHealth board members on the line today and HonorHealth Foundation trustees on the line as well. We also have several leadership donors to this project. So donors, board members, trustees, thank you for your extraordinary leadership, generosity, and commitment to our mission. We truly can't do it without you. 1 in every 3 adults in the U.S. will suffer from heart disease, and the challenge is growing in our community. We must grow to be ready for the patients that depend on HonorHealth to provide expert heart care when they need it most, where they need it most. First, you will hear from Dr. David Rizik, Chief of Complex Interventional Cardiology, and then from Dr. Maulik Shah, Executive Director of HonorHealth Heart Care and the new Heart Care Center, Cardiovascular Center of Excellence. I know we all look forward to hearing from these esteemed leaders. Our physicians will make their presentations, and then we will open the webinar for questions and comments. We are eager to answer questions you may have. Please use the Q&A feature in the Zoom to submit questions as they arise. At the end of both presentations, we have allotted 15 minutes to answer as many questions as we can. Dr. Rizik, I know our guests are very interested to hear from you. Without further ado, welcome Dr. David Rizik.
Thank you very much. Can you hear me okay? Great. I'm going to try and make physician scientists out. If you could put my slides up, I'm going to talk to you about a few things in which there's a number of areas in which we lead the country and even the world in clinical research and clinical investigation. And I'm going to share several of those areas with you. May I have my slides?
You may advance them.
There we go. I'm going to be showing you some excerpts from the PBS documentary Scattered Denial, which I wrote and co-produced, and it's now showing on PBS. This is what we call aortic stenosis. This is the aortic valve. The aortic valve is a one-way door out of the heart. And we've been treating patients with aortic stenosis for 50 years with surgery. But in the last 13 or 14 years, we've been treating these patients at HonorHealth with non-surgical catheter-based technologies. Now, of course, we are doing this in collaboration, not in competition with our surgical colleagues. On the left, you see a normal aortic valve, and I think of the aortic valve as the front door of the heart. It's how blood gets out of the heart. It has to go through the aortic valve. When it becomes stenotic, generally with age, generally after age 65, it accumulates calcium, as you can see on the right, compared to the normal aortic valve on the left, and then it doesn't open quite as well. Now, in non-surgical aortic valve treatment, what we call TAVR, and that stands for transcatheter aortic valve replacement, we place a catheter in through the leg, and we pass this long tube up to the heart, and that tube contains within it a new valve. So we don't have to cut the chest open. The opening in the leg, the catheter-based opening in the leg, is about the size of an ink pen. And then what we do is we place the valve, and the valve opens up. And basically what we've done is replaced the aortic valve, akin to what surgeons have been doing for the last 50 years, without even opening the chest, just going up through the leg. Now, where did this idea come from? I think you all understand the concept of the coronary stent, where we place a stent from the leg into a coronary artery. It's a piece of metal mesh. And actually, what's very interesting about this is that idea for doing transcatheter or non-surgical valve replacements came from the coronary stent. And this is what the coronary stent looks like. And actually, this is Henning Rudd Andersen of Denmark, and he is the inventor of the transcatheter aortic valve implant, or TAVR, and he considers Scottsdale, Arizona, the birthplace of TAVR, and he and I have become very good friends. And it's very interesting how this came about. He said, I got my inspiration when I was at the Phoenician in Scottsdale, Arizona, listening to a doctor talk about stents. And I thought, if I could make the stent diameter bigger and put a valve leaflet, a biological valve inside the stent, we could replace aortic valves in the case of aortic stenosis. And this is what the coronary stent looks like. And Scottsdale
When
is
I came up with the idea 32 years ago, nobody believed in it. People said that, I remember my own professor, he said, Henning, it's impossible, you cannot do that. But go on, try, but you cannot do that, it's impossible. And there were so many people at that time which didn't believe in it. Some of them actually got angry because there was a medical doctor coming and say you can put heart valves in without doing surgery. But it is the normal way. If somebody comes up with let's say, a disruptive invention, which is going to change the world, it takes a lot of years.
a lot of years it took, because 1989 is when he came up with this, and this didn't get FDA approved till 2011. And what he did is he wrote papers to all the medical journals about this new invention of his, and one after another, all of our top journals turned him down and said, we don't want to publish this because it can't be done. And what he eventually did is he stuck to it, and we started replacing, it got FDA approval, and all over the world, we started replacing closed off, blocked off aortic valves with TAVR. So the first thing we do is we go in with a balloon so we can break some of that calcium down, and then we put the new TAVR valve in, and all of this goes through the leg without making an incision in the chest, and this is the TAVR valve. Now, TAVR has been used and FDA approved for valves that don't open, aortic stenosis. But what happens if your valve doesn't close? This is called a leaky aortic valve or aortic regurgitation. And this is just as dangerous to patients as aortic stenosis. And right now, we don't have any good treatments except surgery. And there's a couple of things I want to say about this. I wrote this recent paper and published it in one of our journals. And what I said in the paper is we need less invasive alternatives to surgical replacement for leaky aortic valves, for aortic insufficiency, as we call it. Clinically significant aortic insufficiency is common, 4% in those patients over 60 years of age. Patients die from this frequently. It is underdiagnosed and undertreated. Most patients with a leaky aortic valve don't get therapy. And surgery is the only currently available treatment. And because many of these patients are older and frail, most patients don't get treated. And the TAVR valves we have to treat blocked aortic valves or aortic stenosis just don't work, and we're not able to use them. So how frequent is this leaky aortic valve or aortic insufficiency? A friend of mine, a colleague, Dr. Wu from China, did this study, and what he showed is he took patients over 70, 3,500 of them, and he did echocardiograms. Now look to the far right where you see aortic stenosis. Aortic stenosis was only seen in 1% of those patients, but look at leaky aortic valves. It's 14-fold higher. So this is a significant problem, and there's a high mortality because of this. So let me give you some statistics about leaky aortic valves. Most patients do not get surgery. 75% of the patients do not qualify to get surgery. If you are diagnosed with a leaky aortic valve, aortic insufficiency, your average or median survival is 1 year. Now, 75% never get surgery, but for those who do get surgery, their 1 year mortality drops from about 50% to less than 10%. So it's very important for us to have new valves to treat this. And this is a new TAVR valve specifically for treating aortic insufficiency. And what it has is these anchor rings, because normal TAVR valves won't stay in place. So we have these anchor rings on this new TAVR valve. This is called the J valve, and we're one of 5 centers in the world implanting this. There's only 5 centers in the world. And what this valve does, the anchor rings come down and grasp or hold on to your God-given valve, and it holds it into place. And we've done now more of these than anyone in the United States. And there's only one center in China that has done more of these than HonorHealth. This is our first trial. It was called the EFS, or Early Feasibility Study. These are the 5 centers in the United States: Cincinnati, HonorHealth, Swedish in Washington, in the state of Washington, Ron Waxman, my friend from Washington, D.C., and Peter Fail in Louisiana. And this is a great example of how this works. If you look at that picture to the right, you see that big blue flame going backwards. And over time, that leaky valve, that blue flame, is an ultrasound marker of severe leakage or severe aortic insufficiency, and that causes the heart chamber to enlarge. What we did on this patient, we got access in the leg. You can see us getting access in the leg to the left. And then we advanced the valve in this catheter-based method all the way up to the aortic valve. And now you see the picture to the right, those anchor rings. The animation to the left shows the anchor rings. This is an actual case that we did to the right, showing those anchor rings, how they hold on to the valve, and the animation of the implant and the real world implant on that fluoroscopy to the right. And there's the valve being implanted. I'll leave it run one more time so you can see it. And there's the valve going in. Okay. And this is the final shot of what this looks like. And this patient, who's 82, was taking care of her husband. He's disabled. Now, remember that big blue flame that we saw in the left picture? Look how it is completely gone on the right. And this patient is without symptoms and doing fantastic. Now, we looked at our outcomes on this, and the things we worry about are, did the patient die? Did the patient have a stroke? Or did the patient need a new pacemaker? Because sometimes after we put valves in, that's what happens. Look at the data here. No deaths, no strokes, and no new pacemakers. Now, one patient in our group did die, but that was days after he went home. Unfortunately, he choked on a piece of food and he died. That was the only death out of 15 patients, but none of them due to the valve. So this is really a highly, highly successful procedure. Now, right next to the aortic valve is the mitral valve. And right now, there are no catheter-based replacements for the mitral valve when the mitral valve leaks. And you see that blue or purple color going backwards through the mitral valve. You see the mitral valve there in this animation. And then up in the atrium, blood is going backwards. And you'll see on the animation that blood going backwards. There, that shows the leaky aortic valve. And to the right is an ultrasound picture. That big orange or yellow flame that you see, that's the blood going backwards. What we will be implanting soon, because there's no other replacement except surgery, is a catheter-based device called the InnoValve. And this is how the inner valve works. You come up through the leg, just like in a TAVR, but now we're going to replace the mitral valve. The valve comes down, it grasps the leaflets, it twists and turns, and then the valve is implanted. And this is a completely non-surgical catheter-based valve replacement for patients who are not surgical candidates. And this is the next valve that we will be using to treat leaky aortic valves. Now, this is a very important slide. I'm sort of a data geek. And so if you see the far left graph, you see red and yellow. Those are patients with moderate and severe leaky mitral valves. And look at 30 days, 3 months, 6 months, and 12 months in green, patients who have absolutely no leakiness or regurgitation of that mitral valve. We're really excited to be one of 4 or 5 centers in the world doing this, and I believe this is going to be a game changer. Now, what I've told you is my professional obsession. It's what I think about all the time, trying to advance new technologies. It's all to me about patient care outcomes and advancing new non-surgical catheter-based technologies. That's been my professional obsession for 30 years, publishing high-level evidence clinical trials. But there is a downside. All of these require fluoroscopic exposure or X-ray. Every one of these procedures is done under X-ray guidance. And I think after 35 years of doing this, there's a sobering realization that we may have blithely regarded the hidden dangers of our profession. What do I mean by that? We as physicians, every time we go into the cardiac catheterization laboratory to perform one of these procedures, we're exposed to radiation, and we are exposed to orthopedic long-term consequences. You see, we do these X-ray procedures and we wear a lead apron, but that lead apron doesn't cover our head, our neck, our face, our arms, or our legs. So we're exposed to radiation, and by wearing this 20-pound lead apron, we all develop orthopedic consequences, long-term spine, hip, and knee problems. So HonorHealth is working, under my direction, HonorHealth is working on trying to decrease the amount of radiation that doctors get, because that lead apron isn't a very good shield for us. So we have to worry in our profession about cancers and reproductive concerns in women, and even cataracts. 50% of us develop cataracts. We also, because that lead apron is so heavy, interventional cardiologists, about 75% develop orthopedic and spine issues. And despite the great advances in interventional cardiology over 50 years, our history is replete with tragedies.
I think I felt this radiation cannot hurt me. It can't hurt me. I felt indestructible. Obviously, I didn't know what I was talking about, did I?
I was diagnosed with breast cancer in 2021.
I began to develop multiple skin cancers, mostly on the left side of my body, in my left lower leg, my left forearm, my left hand, my left shoulder, my left cheek, my left temporal area. And
these are just a few examples of friends and colleagues of mine from around the country who were exposed to radiation and developed cancers. And one of the closest was Ted Dietrich, who died of a brain tumor. The amount of radiation we get is incredible, and we're doing more complex cases every year. So we've got to find ways of protecting our doctors and our nurses. And we're doing more cases. I don't know how many of you have had a cardiac catheterization. We're doing more cases from what we call radial access, or through the wrist. And it's harder to protect our physicians. In that middle graph, you see in red the radiation exposure that we get when we use the wrist, in blue when we use the leg, And so it's more difficult to shield us when we're doing these radio cases. The American College of Cardiology did a survey 8 years ago. 50 to 70% of us have orthopedic issues chronically, and 50% of the doctors said they were going to retire or cut back. And we're losing our cardiologists. There's also an issue with women in cardiology. Women don't want to go into interventional cardiology. Women are excelling in general cardiology, but fewer are going into what Dr. Shah and I do, and that is interventional cardiology, because they're concerned about radiation exposure during the childbearing years. So we have developed, and I'm going to go quickly here now, we have developed a new shielding system. And this is what this new shielding system looks like. It's called Protego. And Protego allows us to take the lead off our back and give us enormous protection from radiation. And this is what it looks like. In green is what we get now, and in red is what we get with this new shielding system. Both at the waist and the thyroid, it's a 99% reduction in radiation exposure. And we've done the largest trial ever performed in this, and this is now FDA approved, and we're hoping to get this out at all of the HonorHealth programs. I'll leave you with this last slide. OSHA allows us a certain amount of radiation per year. It's 5 rems or 5,000 millirems. I could take the lead off my back and use this new device and be exposed to 400 cases a year and be exposed to about 0.5% of what I'm being exposed to now. That's an amazing benefit for our doctors and nurses. I could do 1,000 cases this year and be exposed to less than 2% of what I'm being exposed to now. And I think, very importantly, as the father of 4 daughters, this is going to address the concerns that women cardiologists have about going into our profession. Now, I just wanted to give you a little taste of some of the groundbreaking technologies, both in terms of how we treat patients and how we make the workplace more safe. We have so much support from the leadership at HonorHealth, from the Research Institute at HonorHealth, and I hope I hope you enjoyed hearing about these things as much as I enjoy talking about them.
Wonderful. Thank you. Thank you, Dr. Rizik, for sharing this fascinating work and for your passion, not only for your patients, but for your colleagues and other healthcare professionals. This is very meaningful for all of us. Next up, we have Dr. Maulik Shah, Executive Director of HonorHealth Heart Care and the new HonorHeart Cardiovascular Center of Excellence. It is an honor to have you with us today, Dr. Shah. Take it away.
Hi. Thank you, Ashley. Good afternoon. Thank you, everyone. Ashley, you used the perfect word to describe Dr. Rizik. If you can go to the next slide, please. Dr. Rizik is one of the most passionate people that I've been around, and he's dedicated to this world. Just to share a true story about Dr. Rizik, when I first got here, when I was starting here, we have a young family, and my daughter was born, and about 30 minutes after she was born, I needed to go see a patient.
So what do
30 minutes after she was born, I needed to go see a patient. And my wife was okay with that, but I had to run because somebody was sick at Shea Hospital, and that's where we delivered. And I told the story to Dr. Rizik, both just to share the story and also to impress him as to how dedicated I was. But then he told me, actually, when his daughter was being born, with his when his wife was giving birth to his daughter, he actually went in the middle to actually go treat somebody who was having acute MI with a cath procedure, and did one up me on that. And I asked, was his wife upset about that? And he said no, because he actually met her during the treatment of one of his wife's or future wife's family members. So David is one of the most accomplished, hardworking, diligent people that I see. He's super dedicated to everything he does, and he's an inspiration to all of us. He's a world-class physician. And so today, I want to talk to you about how world-class physicians, world-class talent actually needs a world-class facility. And so that is the HonorHeart Cardiovascular Center of Excellence. This is something that many of you have contributed to and have supported with your goodwill and support throughout the last few years. And we're about to go live with it. And so today I want to share with you where we're at. But before we do that, I want to actually talk to you about our HonorHealth cardiovascular program and really highlight our performance, our growth, our talent, and our momentum. Some of you know this, but it's important to recognize that our cardiovascular team at HonorHealth is one of the largest in the Southwestern United States, and probably is the largest employed group in all of Arizona. So we have more than 50 employed cardiovascular physicians that have entrusted HonorHealth with their future. And this is just a testament to the success that we have had in treating physicians well and building a program that people want to be a part of, and then a place that is supported with doing the most advanced and progressive technologies and treatment therapies that are out there, some of which Dr. Rizik highlighted. We have one of the largest programs in volume for coronary stenting or PCI, cardiac surgery, and ablations, which are the treatment of abnormal heart rhythms. We have physician scientists here that are nationally recognized at leading some of the biggest trials in all of medicine across the nation. Just to give you an example of that, our electrophysiology director, Dr. Rahul Doshi, has had his work published in the New England Journal of Medicine 3 times in the last 14 months alone. So the New England Journal of Medicine is one of the most prestigious journals in all of medicine, and just gives you a sense of the caliber of work and the impact of work that some of our physician leaders are doing. And then the campus at which our Honor Heart Cardiovascular Center of Excellence build-out, or Heart Center build-out, is going on. It has been recognized consistently as one of the top 100 hospitals for both cardiac care and heart surgery care. So that just gives you a sense of where we're at with respect to our performance. Sorry, this slide doesn't look quite right here. Jessica, do you want to fix that for us? It looks like when they merge the decks. I can speak to it while they're doing that as well. But things of note are, with respect to just sort of our talent that's come in here over the last few years, we've had a number of physicians that have been recruited for some of the top caliber institutions in the country, including Mass General, Cleveland Clinic, Vanderbilt, and Stanford. And that's just in the last 24 months. And some of the areas that these physicians have focused on include artificial intelligence, vascular medicine, and the treatment of people that need artificial hearts. Jessica and Ashley, if you can help me fix the slides, that would be helpful. There we go. All right. And then while our program has grown quite a bit, the reality is this, that we've grown in volume, grown in talent, grown in performance, but we've also grown in the right things. So we are now a center that's focused on education. In the last few years, in the last 5 years in particular, we've created cardiology fellowship programs in general cardiology, interventional cardiology, electrophysiology, and vascular surgery. So we are training the next generation of leaders within cardiovascular medicine. In addition, as you may have read, we've had the expansion of HonorHealth that's gone on to 3 new hospitals in 3 new geographic areas. And because of the work that we've done in the cardiology fellowships and education and graduate medical education, we've been selected as a whole system to partner with Arizona State University for their School of Medicine. So we're excited about what the future holds for us at this time. I'm going to skip that just because the slide's not coming out quite right. But I just wanted to give you a sense of what programs and therapies that are out there. So we do have new programs that have started in cardiometabolic disease, cardiovascular sports medicine, as well as a left ventricular assist device or heart transplant programs that are coming up. So with machine devices that can actually support people while they're in their worst state with congestive heart failure or after an acute heart attack. So all of those programs, all of that talent, all of that momentum has led us to this point of building an HonorHealth Heart Center at the Shea campus. And this Heart Center campus actually will focus on treating all of the continuum of cardiovascular disease. So cardiovascular care is evolving, and some of it is getting simpler, as Dr. Rizik alluded to, where people can get in and out of the hospital in a day or less. And so we need to have capabilities for that. Some of the people that are coming in still have traditional bread and butter things that need to be treated effectively, like people that are coming in with an acute heart attack or coming in with abnormal heart rhythms. And some of the people need to be housed in a critical care unit, such as a cardiac care unit, that actually can treat those patients that need to be supported with mechanical devices just to actually keep them alive for a few minutes or a few hours or a few days. And so let me talk to you about what's on this campus and at this heart center. So there's a few things. There are the things that I just mentioned: a dedicated cardiovascular ICU, which we're going to talk about in just a minute, an ambulatory surgery center that's going to be housed within the HonorHealth Heart overall hospital, new cardiac telemetry floors that are equipped with the latest technologies and progressive technologies, a cardiology conference center, an area where we can educate all of these new trainees that will be coming through HonorHealth, and then a cardiovascular wellness and diet session area where we can actually give people access to the right types of food and actually teach them how to take care of themselves and prevent cardiovascular disease. So let's start with one of the most important things, an HonorHeart cardiac ICU. So as we mentioned, we're kicking off a new program called Left Ventricular Assist Device Program, where people can be treated with a device that actually can support them when their heart is not functioning at all, something like Dick Cheney had several years ago. So in this unit, we'll have the most a dedicated area within the ICU that's just for heart patients that are coming out of surgery or high-risk complex procedures. This will actually be an 11-bed cardiac ICU that will be unique to our area in metropolitan Phoenix. So this is one of the areas that is most needed, most exciting, and will be utilized by those patients that have the most complex, critically ill problems that are going on at that particular moment. Next, we have something on the other end of the care spectrum, which is a cardiovascular ambulatory surgery center. So the things that we were doing before in cardiology that were revolving around stenting or pacemakers or things of that nature have become simpler. And most of these things can be done safely within an ambulatory surgery center. However, we wanted the best of both worlds. So we were able to put this surgery center within the HonorHealth within the HonorHealth Shea campus, so that we have all the luxuries of being close to an emergency room and a cardiac surgery center if needed, a cardiac surgery suite if needed, but then have the ability to go in and out quickly outside of the rigmarole and complexities and bureaucracy of a regular hospital. And so we're excited because this is unique. There's no other sort of hospital system around here that has a cardiovascular surgery center on its actual campus. This cardiovascular ambulatory surgery center will be about 15,000 square feet. It'll have 3 cath lab suites. And so we're excited about that particular part of the project as well. This is something where you can come in and out and actually get the care that you want while being able to go home the same day. So for instance, pacemakers, simple stenting procedures, and procedures on your legs to actually open up the arteries. So those will all be there. The next thing, if you can put up the slides again, Ashley, we'll focus on here. This is what the interior design of the actual center will look like. And then the other point that within the heart center will be a cardiac telemetry floor. So the cardiac telemetry floor will actually include state-of-the-art capabilities on the first floor adjacent to the emergency room. So patients who are admitted to the hospital with chest pain, with abnormal heart rhythms can quickly be shuttled over to a cardiac telemetry floor with advanced nursing capabilities and physicians on site to actually treat you so that you can get in and out of the hospital quickly and get the fastest care possible, because sometimes time is of the essence. I think there's some technical difficulties, so I'm just going to speak to the other parts of the program. The other parts of the program include a cardiac wellness area. So the cardiac wellness area will include a cardiovascular juice bar where people will have access to actually heart-healthy food while they or their loved ones are in the hospital. It'll also feature an area where you can learn and get your own blood pressure checked and other stuff checked while you're there waiting for your patients or loved ones to get better. And then finally, there'll be a cardiology conference room, which will house our cardiology fellows, cardiac surgery fellows, and be a conference room at which we can actually gather together, learn from each other, and review the most complex patients and complex cases so that we're all on the same page. So, the final slide on the deck, if it was up there, would actually show what our vision is. And our vision, our goal is to be the preeminent cardiovascular center of the Southwestern United States. We want to be able to be the industry leader in treatment of most complexities of cardiovascular care. And we take it very seriously that we are accountable for the care of this community. On a personal level, I just want to say thank you to so many of you. Your positive thoughts, your goodwill, your contributions to this program are saving lives, advancing technologies, and really creating the top cardiovascular program in the state of Arizona, and if not beyond. So on a personal level, from all of my colleagues at HonorHeart, thank you so much for everything that all of you do every day. Ashley, David,
Thank you.
Yeah, only Maulik Shah could have a technical difficulty with his slide deck and give the talk off the top of his head and still make it as interesting as if though you were looking at the slides.
I'll second
I've
that.
learned from the master, David.
Yeah, give him a clap. That's what.
Yeah, I like
that was impressive.
Very impressive. Well, I have to say thank you, Dr. Shah. I'll add a little antidote here that's not in my talking points, but each time I listen to this team, each and every time I listen, not only am I completely impressed and amazed by the work that they are doing, but I find myself extraordinarily grateful that we have such excellence and sophistication in the latest and greatest heart care and cardiovascular innovations available to us right here in our community. I saw a comment come through on the Q&A, and just simply someone says, I just wish to say that I am most grateful that my cardiologist is Dr. Shah, who has consistently been a wise, kind, and diligent caretaker of my heart before and since my aortic valve replacement. And time again, messages come across my deck. Dr. David Rizik gave me my life back. So with those two tones, what I'd like to do now is open it up to Q&A, and we do have quite a few that have come through here. But the first one I'd like to ask you is to you, Dr. Shah. You mentioned 50 employed cardiac physicians at HonorHealth. Can you share what it means to be employed by HonorHealth versus affiliated?
Yeah, absolutely. So we have what's called a pluralistic model. We have so many board members that are on the call here today that have really led the program here for the entire HonorHealth system for so many years. And the key to our success over time is to recruit and align with the most talented physicians that provide the highest quality care to our community. And over time, so many of these physicians, some of whom were independent or running their own clinic, have entrusted HonorHealth to actually run their clinic and to become completely employed by our health system. And it's just a testament to the fact that people trust HonorHealth with their care as well as with their actual careers. So that we're very proud of that. It's a testament to the commitment that the board and executive team has put in to invest in the cardiovascular program, because physicians usually come here if they know you have the talent, infrastructure, teammates, and commitment from the administration to continue to build out a strong program. So the most important thing to tell with that is that these were hand-chosen 50 physicians that came to HonorHealth, and we have employed them to become completely aligned with our health system. And it's just, again, a show of faith that the physicians have that HonorHealth and HonorHeart cardiovascular program are going in the right direction.
Wonderful, thank you. Another question for you, Dr. Rizik. How many TAVRs have been done here at HonorHealth?
Yeah, thousands.
That's a good question.
Thousands and thousands. Yeah. I've done over 2,000 myself. The number keeps growing. We have 2 centers now, the Shea campus and the Deer Valley campus, and they do them every week. Operators, it's an interesting dynamic. In the 90s, cardiologists and surgeons worked in competition with each other. The beauty about what we do today, whether it's in the coronary world or TAVR or valve, is we work in collaboration, not competition. And that has really improved the outcomes. And we do thousands of these, and the outcome data, I mean, when you think about it, 95% of our patients go home the next day. It really is a remarkable technology. I saw one of the other questions is where the most critical needs through philanthropy. And I'll tie that in to the last question, and that is innovation and research, and to be innovative and to execute research and to publish these papers and to be on the front line. And I will say, we have the largest clinical footprint in research and innovation in the Valley. It takes infrastructure. And the type of infrastructure that Dr. Shah just spoke of is central to being innovative, doing research, and being able to bring TAVR to patients who previously, just a decade ago, had no option. So I tried to tie a few answers or a few questions
Thank
into
you.
one answer, but we're really blessed with the talent pool we have.
And I would just add to that, just the legacy of success. So we were the first program to do a commercially available transcatheter valve replacement nearly a decade ago. And those patients, as David alluded to, were critically ill. We had a 98-year-old patient that had no other surgical option at that time. And we were able to do the transcatheter valve replacement procedure to give that husband a chance to actually take care of his sick wife later in life. So it was an amazing thing. And just over the course of the time, because we have such a strong reputation, Dr. Rizik is able to have access to the next generation, latest technologies in valve therapy that help give us, our patients, the most personalized, individualized, and advanced therapies possible in valve replacement and valve therapies.
Great. Well, on that topic of research, we have a question. Is there any research on repairing 30-year-old cardiac bypasses? Interesting question.
Well, we have a number of technologies for 30-year-old bypass grafts. As they degenerate, you can always put a stent into those degenerated bypass grafts. And one of the, I would say, the most forward-thinking approaches we've taken is we've built a really, really great group of interventional cardiologists who can now, with the techniques and technology and the innovation we have, go back to the original arteries that were bypassed, even if they've been blocked for 20 or 30 years, and open those original bypassed arteries. In other words, the God-given arteries. So while we have approaches and techniques to open up the bypasses themselves as they degenerate or close off, there's a real priority to going back to the original diseased arteries and opening them. And we built a team of experts who are specifically trained in doing that. I think that's an excellent question. And most people don't know that we're really rolling the clock back to the original disease process and opening those arteries.
And that team that David alluded to, just to add on to that, are people from high caliber places. So just to put in perspective, Dr. Taral Patel, who Dr. Rizik recruited here, was trained at Duke, is nationally recognized as one of the thought leaders in the treatment of chronic total blockages, and doing that without doing surgery, just through stenting. So that's the exciting part of the growth that we're seeing here and the talent that's coming here.
Right. Well, and great facilities also recruit great talent along with other great talent. So going to facilities, I see a couple questions here. Everyone wants to know when this new project will open, where we are in the construction process, and what is the projected opening date?
Yes, so groundbreaking has already happened. So thank you so much for everyone's support on that. We're excited that the progress is going on pace. So we think we're going to have the actual certificate of occupancy to have people walk in and out in December. So that'll be exciting. One of the first two things that will be opened, one will be the cardiac ambulatory surgeries. One of the first three things, the cardiac ambulatory surgery center, or the ASC. So that is where some of the patients that are now currently being done in the hospital will have the ability to do their pacemakers or stents in the state-of-the-art ambulatory surgery center. The conference room for the education of our fellows and residents will be open at that same time. And then the new advanced telemetry unit for those patients that are coming in for observation level care or just care for things such as abnormal heart rhythms and chest pain will be open in early 2025 as well. And then after that, in the summer, construction on the cardiac ICU will start, and then we're hopeful by 2026 that the ICU will be completely open for everyone.
Wonderful. And and one other question says that we have 3 cath labs up at Shea already, and we're projected to have 3 new cath labs in the new center. So will all 6 cath labs be open at the same time next year once we go live for that
Yes.
part of the project?
Yes, there is a bottleneck right now. We have so many patients that are coming to us for their care, and we could use the facilities and beds and cath lab suites. So we're excited about that. And then what probably will happen is that the simpler procedures will shift to the ambulatory surgery side, and then those complex procedures that need to be in the hospital for complex procedures and that require more hours will be done in the hospital.
Mm-hmm. And I see one other question here. With these new therapies and these new technologies, will there be a protocol to stay on blood thinners for the rest of your life?
Boy, that's what we are, we call that blood thinner de-escalation, and that is one of the real focuses of what we're doing. For instance, let me give you a couple of examples. It used to be that if you had atrial fibrillation, you were on blood thinners for life. Now we have implantable devices that, in essence, filter or prevent blood clots from developing if you have atrial fibrillation. They prevent stroke, they prevent bleeding, they represent a cost savings to the patient. You're not buying blood thinners every month. And so we are already going in that direction to simplify medical regimens and to get patients off blood thinners. The new stent technology. If you look at the new stent technology, the stent struts are thinner and they heal far better. The drugs that we put, the drugs and polymers that we use with these stents are much slicker than they used to be. And now, instead of leaving patients, at one point we were leaving patients on for 2 or 3 years on their blood thinners after a stent. Now, the new data, the latest data that has just come out is talking about 1 month of blood thinners, and that's all. So there have been so many technology evolutions and revolutions that I think as time goes on, we are going to abbreviate or de-escalate the length of time patients are on blood thinners.
Thank you. And we do have one last question, which we'll take before we do our closing remarks. And that is there, let's see, I had a failed attempt CTO, PCI, RCA using multiple methods. Is there anything new on the horizon that might help me?
I would say 2 answers to that. One, who did it? And you don't have to tell me that. But I would definitely give our CTO team a crack at this to look at it. And then you also have to weigh, there's just some blockages that are riskier to try and open than the potential benefit. But I would tell you to approach Terrell Patel and Ankur Gupta. These are formally trained individuals, and if anybody can open it, it's them. There's nobody better around the valley in terms of opening these CTOs. I love the way you put all the acronyms in there. And if they are the ones who looked at this, then I would say they have a really good sense of risk and benefit. And when something is just, what's the World War II expression, a bridge too far, they have a really good eye for those things.
Well, thank you. Thank you very much. So I just want to say it is absolutely humbling to think about the work that you all are doing for our community. Dr. Rizik, Dr. Shah, thank you for your time today. It is so exciting to see what's happening at HonorHealth in Heart Care and our new Cardiovascular Center of Excellence, which I know we're all very excited to see. The 2 words that kind of struck me when talking about philanthropy, research and innovation. It takes infrastructure. I'm just going to say that again. It takes infrastructure. Thank you, Dr. Rizik, for saying it so beautifully. Thank you to all of you who have invested in our heart campaign already, more than $45 million to transform healthcare by expanding the Cardiovascular Center of Excellence. This project is nothing short of extraordinary. So for those of you who want to learn more and who want to get involved at any level, we encourage you to reach out. We encourage you to get involved. And we encourage you to think of this project as you contemplate your year-end support and any other philanthropic objectives you might have with you and your family. So you will be receiving a post-program survey, which will include instructions on how to connect with a gift officer if you'd like to learn more. Now, of course, should you be interested in connecting right away, which I hope you do, you may respond to the event's email where you received today's program information. So once again, I just want to thank you all for joining us. We have a lot of people on the line. It's been a great group, and the questions do keep coming in. But I want to thank you all, and I want to thank you, Dr. Shah and Dr. Rizik, for the extraordinary work that you do. Our community is very grateful.
Thank you all. We appreciate it.
All right. That concludes our webinar. Have a wonderful day, everybody, and thank you for joining us and for your support of the foundation.